Hi everyone, myself Dr. RACHANA, Associate Professor in the Department of ENT, Reddy Medical College for Women's in Hyderabad. In today's learning session, I shall enlighten you all about tonsillitis, a very commonly seen disease among the pediatric age group. Let's see the objectives of today's learning session. So at the end of this session, the learner should be able to describe the tonsillar bed anatomy, identify the types of tonsillitis, enumerate the clinical features of tonsillar hypertrophy, both acute and chronic, describe the principles of management of acute and chronic tonsillitis, interpret the diagnosis from history and examination. The synonyms of a tonsil. So there are various types of tonsil. We have pharyngeal tonsil, that is adenoid, then the palatine tonsils or the facial tonsils, the tubal tonsils around the eustachian tube, and lastly the lingual tonsils. So today we are going to discuss about the palatine tonsils, which is also called as the facial tonsils. Coming to the development of the tonsil, tonsil is developed from the second pharyngeal pouch. Epithelium. Tonsil is lined by non-keratinized stratified squamous epithelium. So here we can see the picture of a tonsillar fossa showing the tonsils. So this fossa anteriorly has got anterior pillar, posteriorly has the posterior pillar. So if you see, the anterior pillar is formed by the palatoglossus muscle and the posterior pillar is formed by the palatopharyngeus muscle. So does a tonsil have a capsule? Yes, the tonsil has a capsule. So we can see in this picture, this one. This is the tonsil and this is the capsule of the tonsil. Okay. This is the bed of the tonsil about which we will be discussing in the coming slides. So muscles that are forming the tonsillar bed. We have basically two muscles, superior constrictor and styloglossus muscle. So if you can see in this picture, this is the tonsil, the capsule of the tonsil. So let's see the one by one the layers of the tonsillar bed from medial to lateral. So initially we have the capsule followed by the loose areolar tissue in which is running the paratonsillar vein. Then we have the pharyngobasilar fascia followed by the superior constrictor muscle, and then we have the buccopharyngeal fascia, then a styloglossus muscle. So here runs the facial artery, and just immediately behind the styloglossus we have the submandibular gland. And in the upper pole it is related to the ramus of the mandible. So this was about the bed of the tonsil. So what is present in between the tonsillar capsule and the bed of the tonsil? That is this yellowish demarcation. It is the loose areolar tissue. What is the importance of this loose areolar tissue? It's very important because it is the plane of dissection during the tonsillectomy. And it is the place where the pus is collected in a condition called quinsy, which is also called peritonsillar abscess. So once again, another picture to describe the bed of the tonsil. This is a tonsil, then the capsule, and then we have the loose areolar tissue, paratonsillar vein, then the pharyngobasilar fascia, superior constrictor muscle, buccopharyngeal fascia, palatoglossus muscle. Then we have the submandibular salivary gland here and the ramus of the mandible with the muscles, medial pterygoid and the masseter. And in between runs the facial artery and its branches, supplying the tonsil. So this is the loose areolar tissue, which is the plane of dissection during tonsillectomy. And it is this plane in which the collection of the pus is also there in a condition called quinsy, which is a peritonsillar abscess. Then two structures, basically the styloid process and glossopharyngeal nerve, they lie in relation to the lower part of the tonsil, that too posteriorly. Why it is important? So in patients who come with elongated styloid process, so they can have the throat pain. And when we try to palpate in the tonsillar fossa posteriorly, the styloid process can be, which is elongated, can be felt. And in quinsy and also after tonsillectomy, the reason for ear pain is because of the relation of the tonsillar fossa with the glossopharyngeal nerve, which is a part of tympanic plexus supplying the ear. That is the reason for ear pain. And point to be remembered is, if one has to go for glossopharyngeal neurectomy and also for the removal of the styloid process elongation, we have to do tonsil, remove the tonsil, and then we can go ahead with the neurectomy and styloid process excision. Pulsatile tonsil. What is a pulsatile tonsil? So it is, one has to look whether the tonsil is pulsatile or not. This is because in cases of internal carotid artery aneurysm or an aberrant internal carotid artery, we can find a pulsatile tonsil. The internal carotid artery lies just 1 inch lateral to tonsil. It's so close to it. So one has to keep this in mind. Coming to the anatomy of tonsil, basically the tonsils are lymphoid tissues. So they have a role to play in the immunity. And tonsils are situated in the lateral wall of the oropharynx. They are a part of Waldeyer's ring. So in the Waldeyer's ring, we have the adenoids, then we have the lateral pharyngeal bands, we have the tubal tonsils and the palatine tonsils situated in the oropharynx. And in the posterior one third of the tongue, we have the lingual tonsils. Uh, the tonsil occupy the tonsillar fossa, which is in between anterior pillar and the posterior pillar. So if you see the tonsils, they have two surfaces, medial surface and lateral surface, and they have two borders, anterior border and posterior border. Two poles, upper pole and lower pole. So medial surface, lateral surface, upper pole and the lower pole, and two developmental folds, plica triangularis and plica semilunaris. And then the medial surface of the tonsil has got cleft-like spaces which are called as crypts. They are nearly 15 to 20 crypts. One such a large crypt is called crypta magna. So these crypts usually are plugged with the epithelial and bacterial debris and also the food debris. The lateral surface of the tonsils extend deep into the surrounding boundaries and it is coated with a fibrous sheath. It's an extension of the pharyngobasilar fascia, which is called as the capsule of the tonsil. The capsule is very loosely attached to the muscular wall, but anteroinferiorly it is very firmly attached to the side of the, just in front of insertions of the palatoglossus and the palatopharyngeus muscles, that is anterior and the posterior pillar. So coming to the artery of the tonsillar hemorrhage. So it is the facial artery, which is a tonsillar branch of the facial artery. Then what is the commonest cause of bleeding during tonsillectomy? The bleeding occurs from the paratonsillar vein, which is in the loose areolar tissue. It is also called as the Dennis-Brown vein. So coming to the blood supply of the tonsils. The tonsil is supplied by the branches of the external carotid artery. So we have the descending palatine artery and also the ascending palatine artery, ascending pharyngeal artery, and the tonsillar branch of the facial artery, and also the dorsal lingual artery. These are the blood supplies of the tonsils. So it is supplied by the branches of the external carotid, ascending palatine, descending palatine, ascending pharyngeal artery, and the tonsillar branch of the facial artery, which is the artery of hemorrhage for tonsillectomy surgery, and dorsal lingual artery from the lingual artery. Coming to the tonsillar node. So it is basically the jugulodigastric lymph node which is enlarged during the tonsillitis. It is present in between the internal jugular vein and the posterior belly of digastric. So it comes under level 2 and level 3 of the cervical lymph nodes. This is a jugulodigastric which is seen in between the internal jugular vein and also the digastric muscle. Before going into the acute and chronic tonsillitis, a few words about the physiology of the tonsil. So, it produces both local as well as systemic immunity. Coming to the local immunity, it is the epithelial lining of the tonsil which has got M cell, the antigen presenting cell, which upon the foreign body entry, this antigen presenting cell will be identified by the germinal centers, and these germinal centers are there in the lymphoid follicles. So these lymphoid follicles have germinal centers uh, in which the B cells they form plasma cells, and these plasma cells produce antibodies. So and this is how immunity is produced. Then coming to the systemic immunity, which is basically a wider response to infections. So the same lymphoid follicles have the germinal centers, which produce the antibodies, and also they have macrophages, which have got the phagocytic actions. And other inflammatory cells are also produced. Now, coming to the tonsillitis types, we have acute tonsillitis as well as chronic tonsillitis. So, let's discuss in detail about acute tonsillitis. The commonest organism that causes the acute tonsillitis is group A beta hemolytic streptococcus. The treatment for this is crystalline penicillins, but uh, if they are resistant to penicillins, then macrolide antibiotics or cephalosporins can be considered. The other organisms are Staph aureus, Haemophilus influenzae, Moraxella, and Pneumococcus. And also we have the adenovirus, rhinovirus, Epstein-Barr virus, Coxsackie virus also implicated in the uh, organisms of causing the acute tonsillitis. Now let's see what is a tonsil tummy. So the children who are having this acute tonsillitis, they also present with abdominal pain, and the reason being it's due to the mesenteric lymphadenitis that occurs secondary to the swallowed exudates following the acute tonsillitis. So they are small children, they don't know how to spit, so they tend to swallow these exudates from the acute tonsillitis infections, and this causes the lymphadenitis of the mesentery, leading to abdominal pain. So that is a tonsil tummy. So acute tonsillitis most commonly affects the children of age group 5 to 15 years. It may also affect the adults. Organisms we have already discussed. Let's see the symptoms. The symptoms are basically sore throat. It's a generalized term. So by sore throat we mean there can be throat pain, some discomfort in the throat, itching of the throat. This leads to difficulty in swallowing and accompanied by fever and also the ear pain. The different types of acute tonsillitis are acute catarrhal or superficial, acute follicular, acute parenchymatous, and acute membranous. So, what is acute catarrhal or superficial? Here, the tonsillitis is a part of generalized pharyngitis. So, there will be congestion of the posterior pharyngeal wall along with the tonsillar congestion, mostly seen in the viral infections. In acute follicular, here the infection will spread into the crypts with purulent material presenting at the opening of these crypts, which presents like yellow spots. Okay. And in acute parenchymatous, uniformly the entire tonsil is enlarged and congested. In acute membranous, it basically follows the follicular stage where all these exudates or the spots they coalesce and they form a membrane. Let's see some pictures of acute catarrhal or superficial, follicular, yellowish spots, and these spots coalesce forming a membrane. Acute membranous tonsillitis. So, what are the signs? They'll have a bad breath from the mouth, that's halitosis, a coated tongue, congestion of the pillars, anterior and posterior pillars, as well as the soft palate and the uvula. The jugulodigastric lymph nodes are enlarged and they tender on palpation, and the tonsils themselves are enlarged, congested. So, coming to the management. So, acute stage has to be managed conservatively. So preferably advise bed rest. Plenty of oral fluids are advised. They have to go on for an antibiotic therapy and analgesics and antipyretics. So we preferably give penicillin, so Augmentin 625 mg twice daily for adults, 375 mg for children. Alternatively, cephalosporins and macrolides also can be considered. Antiseptic gargles are a must. Betadine mouth gargles would be ideal. If not, simple salt water gargling in lukewarm water. Analgesics for pain and antipyretics in case of fever. So that was about the treatment of acute tonsillitis. Now, if infectious mononucleosis is suspected, we should avoid giving amoxicillin because it can cause salmon colored rash. What are the complications if suppose we don't treat an acute tonsillitis? It can lead to repeated attacks of tonsillitis of acute stage will go to chronic stage. A peritonsillar abscess, a parapharyngeal abscess, a cervical abscess. So from the tonsil area, it spreads to the surrounding areas. Then it can have an ascending infection into the ear, leading to acute otitis media. Then, because of this, M cells, as I already mentioned about the immunity, they have some cross antigens present in the renal as well as the part. So, because of this, there is all possibility of rheumatic fever and also acute glomerulonephritis and subacute bacterial endocarditis. What is recurrent tonsillitis? So, how can we say now this is a case which is repeatedly getting attacks of tonsillitis? So, there's some criteria. It goes with this: 7 culture proven episodes of acute tonsillitis in 1 year, 5 episodes per year in 2 consecutive years, 3 episodes per year in 3 consecutive years. So, this is the criteria for recurrent tonsillitis: 7, 5, 3. Now, what is the differential diagnosis when we see a white or a grayish patch over the tonsil? So, we should keep in mind all these diagnoses. Firstly, let's begin with a congenital cause: tonsillar cyst. Rheumatic, it can be a foreign body, a simple ulceration, or post tonsillectomy also you can see white patches. Thermal injuries, radiotherapy, corrosive poisoning case. In infections, we have both acute and chronic. So for acute infections, we categorize them into bacterial, fungal, and viral. So under bacterial, acute bacterial tonsillitis, diphtheria, Vincent's angina, acute gangrenous tonsillitis. For fungal, it can be candida infections. Viral, herpes, infectious mononucleosis caused by Epstein-Barr virus, and HIV. Chronic infections, tuberculosis. So all these are the infective causes for a white patch over the tonsil. Pre-malignant conditions also present like white patch over the tonsil, leukoplakia, submucosal fibrosis. Tumors, benign tumors like papilloma, malignant tumors, hard, irregular white patch with granulation and everted edges which bleed on patch. Autoimmune conditions like lichen planus and vaginus also present as white patch. Systemic conditions like agranulocytosis, leukemia, aplastic anemia, and blood dyskaryosis. Miscellaneous conditions, tonsillar keratosis. So the food debris tends to go and accumulate in the crypts. It also presents like a white patch. So it's self-limiting. A tonsillolith, which is a stone formation in the tonsil, a simple aphthous ulcer, and a fibroma. These are miscellaneous conditions. So these were all the differential diagnosis of a white patch over the tonsil. Now, let's go into detail about what is chronic tonsillitis. So generally, acute infections are less than 3 weeks. Beyond that, it's called a chronic tonsillitis case. The etiology of chronic tonsillitis is a simple complications of acute tonsillitis, subclinical infections of the tonsils, and chronic sinusitis or dental sepsis. All this can lead to chronic infections of the tonsils, mostly affecting the children and young adults. The different types of chronic tonsillitis are chronic follicular tonsillitis, chronic parenchymatous tonsils, and chronic fibroid tonsillitis. The clinical features are, so we have a recurrent attacks of sore throat, chronic irritation of the throat leading to dry cough, bad breath, halitosis, difficulty in swallowing, that is dysphagia. Whenever there is an acute attack, there can be odynophagia also, that is painful swallowing, and the speech. It's like a hic speech. The cardinal signs of the chronic tonsillitis are mainly four. Number one, enlargement of the tonsils. So we have grading for it, which we'll see in the coming slide. Then we have Erwin-Moore's sign, which is basically whenever we apply pressure over the anterior pillar, it expresses frank, purulent material or a cheesy material from the cribs, which is seen in fibroid type of chronic tonsillitis. The flushing of the anterior pillars compared to rest of the surroundings, and the enlargement of the jugulodigastric node, which is non-tender. It was tender in acute. So these are the four cardinal signs of tonsillitis. So tonsillar enlargement, Erwin-Moore sign positive, flushing of the anterior pillar, and the jugulodigastric lymph node enlargement. How do we treat? So for chronic cases also, we can try a conservative management whenever there is an acute attack. But the permanent treatment would be tonsillectomy for chronic tonsillitis. So what are the complications? Just like acute, there can be peritonsillar abscess, surrounding abscess, retropharyngeal, parapharyngeal, intratonsillar abscess, a tonsillar cyst, tonsillolith, and rheumatic fever and glomerulonephritis. So how do we grade tonsils? So basically we take the anterior pillar as well as the uvula as the reference points. So we have four grades. Grade 1, where the tonsil occupies 25% of the anterior pillar. Grade 2, it occupies 50%, that is in between 25 to 50%. Stage 3, in between 50 to 75% of the anterior pillar. Stage 4, it's more than 75%, nearly it can be even 100%, that is called hissing tonsils. Okay. These are the tonsillar grading. Let's see some differences between acute membranous tonsillitis and diphtheria tonsil. So diphtheria also presents like white patch and acute membranous also presents like white patch. So let's see how we differentiate. In acute tonsillitis, we have the history of recurrent tonsillitis episodes, whereas diphtheria has got only when it is exposed, there is diphtheria. Here in acute membranous, there is high grade fever with chills. In diphtheria, it is normal or mild fever. In acute membranous, tachycardia is proportion to fever, whereas in diphtheria, tachycardia is out of proportion. Here, throat pain is present in acute membranous. Here in diphtheria, it is absent. In acute membranous, membrane is limited to tonsil. It can easily be removed. Whereas in diphtheria, the membrane which is given which is called a dirty gray membrane, it extends beyond the tonsils. It cannot be easily separated. It leaves a raw bleeding surface. In acute membranous, jugulodigastric lymph nodes are enlarged and tender. In diphtheria, we have a marked lymphadenopathy, a bull's neck. And in acute membranous, albuminuria is absent, whereas albuminuria is present in diphtheria. Corynebacterium diphtheria is negative when a throat swab is taken for culture and sensitivity in acute membranous, whereas it is positive in diphtheria. So these were few differences. What is an orange tonsil? It's basically seen in Tangier's disease, which is a familial hypolipoproteinemia condition. So in that condition, we find a orange colored tonsil. What is the diagnostic sign for a tonsillar malignancy? Definitely, induration will be there on palpation, and the commonest type is squamous cell carcinoma. What if only one tonsil, that is unilateral tonsil, is enlarged? What are the differential diagnoses? We should rule out lymphomas, squamous cell carcinoma, leukemias, foreign body, plasmacytoma, sarcoidosis, candidiasis, peritonsillar abscess, and a parapharyngeal abscess or a tumor. So all these things, and also a tonsillolid. So these are the differential. Basically, we have to rule out firstly lymphomas and the squamous cell carcinomas. Now coming to investigations. So first and foremost, we take a throat swab, send it for culture sensitivity, identify the organism. Thereby, accordingly, we can prefer the antibiotic of choice. To rule out hemopoietic disorders, we also ask for peripheral smear, Paul Bunel test in case diphtheria, X-ray PNS. So chronic sinusitis can lead to descending infections leading to chronic pharyngitis and chronic tonsillitis. So we have to rule out sinus infections as well. And adenoid. So most of the time tonsils and adenoid both being lymphoid tissues. So adenoid enlargement also should be ruled out. Next, the most important investigation, ASO titer, anti-streptolysin O titer. A raised ASO titer is one of the most relevant serological index for antecedent group A beta hemolytic streptococcal infections. So, elevated IgG and IgA are definitely found in children with recurrent tonsillitis, which is returned to normal after tonsillectomy. And 3 to 4 years after tonsillectomy, ASO titer also comes down. So, we can go ahead with these immunoglobulin test and ASO titers. If ASO titer is positive, that is more than 400, then they have to go for prophylaxis of penicillin in order to prevent rheumatic fever and glomerulonephritis. In chronic tonsillitis, definitely tonsillectomy is the choice. So, tonsillectomies, let's see the indications and contraindications. The absolute indications of tonsillectomy are obstructive sleep apnea. So, because of tonsillar enlargement, especially grade 4, so they will be having the apneic spells. And secondary to this airway obstruction, they can be having cardiopulmonary issues such as cor pulmonare and alveolar hypoventilation, suspected malignancy in the tonsils, hemorrhagic tonsillitis, and tonsillitis causing febrile seizures. So all this become the absolute indications for doing it. So what are the relative indications? So as already discussed, the recurrent attacks, 7 episodes in 1 year, 5 episodes per year in 2 consecutive years, 3 episodes per year in 3 consecutive years, and 2 weeks of missed school or work in 1 year. Okay, these are the relative indications. And also the keratosis tonsil and peritonsillar abscess and dysphagia due to tonsillar hypertrophy. What are the non-tonsillar indications for doing tonsillectomy? As already discussed, so for doing styloidectomy and also glossopharyngeal neurectomy, we have to go for tonsils excision and also excision of the complete branchial fistula. And whenever we are doing surgical procedures in OSA like uvulopalatopharyngoplasty or zetaplasty, one has to go ahead with tonsillectomy. So these are non-tonsillar indications for doing tonsillectomy. What are the contraindications for doing tonsillectomy? So any bleeding disorders, anemia, epidemic of polio, acute infections, uncontrolled medical comorbidities, we have to uh, not prefer the doing surgery. In Down's child, they have got inherent atlantoaxial instability. So we have to uh, instead of preferring a rose position, we have to attempt a neutral position or go for conservative management. Now, how do we do tonsillectomies? There are various methods. The commonest being dissection and snare method using the cold instruments. Hot technique that's called diathermy, laser, radio frequency, electrocautery, coblation, harmonic scalpel, microdebrider, guillotine, and cryosurgeries. So all the different methods of doing tonsillectomy. What is the position for doing tonsillectomy? It is the rose position where the patient lies in supine, neck is extended with a sandbag under the shoulder. This is the rose position. The surgeon stands behind the head and operates. So the advantage of this position is that there is no aspiration into the airway. Both the hands of the surgeon is free. So we take a mouth gag which is called Boyle-Davis mouth gag. We insert it and after inserting it, we have to take a tonsil holding forceps wherein the tonsil is grasped and pulled medially. An incision is given over the anterior pillar of the tonsils, and then we have to first remove the capsule, and then the dissection starts from upper pole to lower pole. Then finally, once we reach the lower pole, we can either remove the tonsil by putting a snare, crushing the lower pole of the tonsil, and or take help of either bipolar cautery or a scissor and excise the tonsil. So here goes the pictorial description. So once we give the incision, we start the dissection from upper pole to lower pole. Here we first grasp the tonsil, pull it medially, and then do the dissection. This video shows tonsillectomy procedure using the bipolar scissors. So once the cheek is retracted, the tonsil is held with the forceps, and then we start the dissection. See, the tonsil is pulled medially. Once the tonsil is pulled medially, we will be able to visualize clearly and we get the plane. So the plane of dissection is the loose areolar tissue. So using a tonsil holding forceps or a Lux forceps, it depends upon the surgeon. We pull, grasp the tonsil, and then it is the surgeon's method, either cobblator or a bipolar scissor or a simple cold instrument. Different techniques are used to dissect the tonsil, starting from upper pole, then slowly dissection, keeping hemostasis in mind. It is reached lower pole and then the tonsil is excised. So what is the position in which patient has to be kept after tonsillectomy? Preferably in the left lateral position, because in this position the aspiration of clots is prevented into the airway. Immediate postoperative care, we have to watch for the bleeding, keep a check on the vital signs. We have to put the patient on a liquid diet, ice cold liquid diet, so that it helps in control of the bleeding as well as pain. So we can give them plenty of fluids as well. Oral hygiene, gargling is given, antibiotics are given, analgesics are given. The complications of tonsillectomy immediately is hemorrhage. There can be primary reactionary hemorrhage and secondary hemorrhage. Primary is that occurs at the time of operation. It can be controlled by pressure or taking help of electrocautery or a bipolar and or ligation. Reactionary hemorrhage, it occurs within 24 hours of the surgery, can be controlled with simple measures like sometimes just removal of the clot or application of the pressure or vasoconstrictor. Injury to the surrounding areas is another complication. We can injure the tonsillar pillars, anterior posterior pillar, uvula, and soft palate. Injury to the teeth, aspiration of blood, facial edema, surgical emphysema. Surgical emphysema. The delayed complications are secondary hemorrhage, which generally occurs 5th to 10th day post-operative. Sometimes simple pressure uh, or removal of the clot and hydrogen peroxide wash. These are some simple measures which can help in controlling the bleeding, but very rarely profuse bleeding can occur. So we need to take the patient back into the operation theater and under general anesthesia. We try to apply the bipolar electrocautery or approximate the pillars with sutures. Very rarely, external carotid artery ligation is required. And if there is lot of blood is lost, then blood transfusion should be considered. Systemic antibiotics have to be given. Infections and infection spreading to the surrounding areas like parapharyngeal abscess or otitis media, rectopharyngeal abscess possibility, lung complications due to aspiration of the blood, and the scarring in the soft palate and the pillars. What is the average blood loss during tonsillectomy and combined adenotonsillectomy? So only tonsillectomy, about 50 to 80 ml blood is lost, and combined procedures nearly 80 to 120. So it again depends upon the type of tonsillectomy we have done. So the traditional hold method will definitely lead to more bleeding compared to the recent methods of bipolar and coblation method. So that was the end of the session. So before we end it, let's just summarize the key points. We need to know what are all the structures that form the tonsillar bed and the blood supply of the tonsil, what is the types of tonsils, and acute and chronic tonsillitis and their clinical features, and what are the differential diagnosis of a white patch over the tonsil, and what is the cause for unilateral enlargement of the tonsil, and finally, how do we manage a case of acute tonsil as well as a chronic tonsil. So for chronic, it is tonsillectomy. So how we do tonsillectomy, a step-by-step procedure, and what are all the complications. Thank you.